user involvement is about making sure that the voices of people who use the services provided have the opportunity to voice their opinions about the services they receive and the chance to make real sustainable change. And I'm going to come back to this point because it's okay having the opportunity, and you might voice your opinion, or a group of people might voice an opinion, but then what happens to that? Who acts on it? Or does it stay, we just said this? It's a bit like students, I suppose. You might say, actually, Shirley, we said last year that we wanted more library resources. You asked us to fill in these evaluation forms. You said, we said this, but you did nothing. So it's really important that we think not just about the ability to voice an opinion, but then what happens. This is going to sound very negative, but I think it's important that we think about some of the things that shape public perception. And often the big things, because we are part of public, we are in that world. Some things happen and we get worried about it. And sometimes we see a lot of high-profile cases that might negatively influence our view of public sector. So we might see these things and think, oh, the NHS is all bad, the social care sector is not good, the pharmaceutical industry is not doing a very good job. What's happening? So these can really overturn people's opinions about previously what might have been a very positive view about some services. Oh, keep pressing that button. So if we think back quite some time ago, and we think about Haringey Council and the issue around Victoria Columbia, who unfortunately died in very, very bad circumstances, and Baby P, the same thing. People will read and watch the media will form a view, and clearly the lessons learned were a lot of lessons to be learned. In these cases, about how people work together, multi-professional practice and people communicating or not communicating effectively, and issues around that were very, very clear. A common theme there was communication and people and working and processes. It wasn't about people not wanting to do a good job. It was that the processes and the systems and the way that people worked weren't effective. We think about something more recently, and I'm sure everybody in the room cannot have escaped the issues that were raised at mid-staffs. That doesn't mean to say that every single healthcare practitioner in that area was not working to the best of their ability or wanting to do a good job. There were systematic issues connected with how care was managed, delivered, led, etc., governed. Go back some time ago, now when I was a student studying for an MA in sociology and social policy at Durham, I did some essays on this topic. And at the time, the research that was published was starting to question the benefits of the measles, mumps and rubella vaccine. And a chap called Andrew Wakefield was researching in this area and had his work published. And that work was subsequently discredited as being methodologically flawed. It was not considered to be good research. The impact that this had on parents who were going to vaccinate their child was amazingly, the impact was amazing, but it was a negative impact. And we're only just seeing now the recovery rates for people having more confidence in the MMR vaccine. And breast implants and other issues connected with medical devices and drugs, etc. Things happen and people lose confidence. Now, these things might be real, they might be exaggerated, but the point I'm really trying to make here is the public have got a vested interest, and the media are working to try and engage, sometimes in what we might think is bad press. But some of these things are real. Some of these things are serious issues that we need to address in some of these sectors. The Winterbourne Panorama programme, I don't know whether anybody watched this was fairly recently, and anybody working in health and social care must have watched this programme and been pretty disgusted these people are saying here. And you can look at some of these things and think, how did that happen? How did we allow that to happen in that setting as individual practitioners and as the sector? Because some of it isn't about a piece of research that was methodologically flawed. Some of it is about leadership. Some of it is about governance. Some of it is about professional practice. Some of it is about being professional and true and confident. So all of these things have lots of factors why some of these things come about. And I know increasingly, you see these things and you think, what impact have I made as an individual to as working in all these years in health and social care, working in a university that's educating and training practitioners for the future. And it's very disappointing sometimes when you see some of these things, but also it can also make you dwell on the negative rather than the positive. And I think one of the things we need to do is look at the positive, and look at the good practice and learn from best practice. So that becomes the focus rather than the negatives. And I was minded to, I'm probably talking too much now, aren't I? But I'll have to continue because I haven't finished my slides. I'll try and be quick. Felicity Stockwell was a nurse who did some research many, many years ago. It was funded by the Royal College of Nursing. It was one of the first really big pieces of research that was funded. And she wanted to look at difficult patients. And she found that when she went to talk to healthcare practitioners and said, can you tell me about difficult patients? They didn't want to talk to her about difficult patients because they didn't want to admit that they thought some people were difficult. So she changed the slant and started talking about unpopular patients, which I couldn't quite see what the difference would be from in my perspective, but people were more willing to say, what do you think makes a patient popular rather than unpopular? How many people are aware of this work? 1, 2, 3. Just to straight, that's good. So I'm pleased I've put it on. So she was using a theoretical framework which was linked to maternal bonding. And she was arguing that through this theory of maternal bonding that we learn as we bond with our mothers and other people, that certain things make us feel comfortable, certain ways that people may communicate to us and involve us and with us, their presence. And she was trying to argue that perhaps the way some of these practitioners were with people might make a difference to how they were perceived and how these people might act. But basically, some of the key findings are quite relevant still, that she could identify through talking to these practitioners that they could say that some people were popular and some people weren't as popular. But what she did find, I think I've got I just put my glasses on, was that what she says, one disquieting finding was that the least nursing attention was given not to the unpopular patients, but to those who were neither particularly popular or unpopular. And that on all the wards there were some patients who tended to be confined to bed, but not acutely ill, who had no particularly verbal contact with healthcare practitioners, although they welcomed the chance to talk once a conversation had been initiated. So what she's saying is, if you're acutely ill, you get a lot of attention because you require it, often physically. If you are very unpopular, and there she was talking about people who might have some challenging mental health problems, or they might be particularly old or confused. But these days we might say that could be somebody who's got dementia. Those people might get more attention just because they are visible and attracting attention, not in a negative way. I don't mean attention seeking. And yet, so there's these other people who sort of just sit there really quietly for long periods of time, and nobody talks to them. Neither unpopular or popular, just people. So I think if we went back and just did some reading around some of these things, I think in the communication and how we are like people, it might bring some things back to the fore. Okay. I've got my time here. Now, if you want to listen to Felicity Stockwell saying how disappointed she is that this work's still relevant today, you can follow the link. So we try to do some things in health and social care about regulation. We regulate aspects of healthcare now quite significantly. We regulate the professions. There's a big debate to be had about whether regulating the healthcare professions will make a difference. It's often thought to be a bit of a spurious link, but that debate isn't for today. Leadership and providing people with resources. So in terms of trying to balance out public concerns versus public confidence, the Department of Health is definitely and has definitely been committed for a long, long time, well before, even before this 2000, about making sure that if we involve service users, we will get improved services. So you'll see things like this everywhere. What do you think? That's it. Not about what do you think, but what can we do? Recently, I mean, there's a lot of history in this. And if you're really interested, you can study this in detail in further study. But recently, the Prime Minister requested that Sir Bruce Keogh, who's the National Medical Director of the NHS, should undertake a review of the quality of care and treatment provided by NHS that have high mortality rates. So 14 trusts were selected, and he did this by looking at 2 different ways of calculating mortality rates. And I've just pulled some things out that I thought would be interesting that would inform your discussions later. Poor standards of care don't always show up in mortality statistics, and we must remember that. People can still have experienced poor standards of care. Clinical effectiveness and patient experience and safety are the 3 key areas that he's considering that make quality. And the review teams placed an emphasis on listening to feedback from staff and patients, because staff often have very important things to tell people that would help enhance services, as well as listening to students. The big thing for me is that there was pockets of excellence where he looked, but this was balanced out by significant areas for improvement in every single one of the trusts. So variability remains. I don't know whether anybody can remember about the postcode lottery phrase we used to use. It was on the catwalk quite a few years ago. It seems that there is still an element of that which pervades. So I've just picked out one of the ambitions in this report, which is relevant for today, that patient carers and members of the public will increasingly feel like they are being treated as vital and equal partners in the design assessment of their local NHS. And this really is the same in social care as well. Obviously, he is acting as from the NHS. And that they should be confident that their feedback is being listened to and how it's impacting on their care and the care of others. You'll see that the way that education is commissioned as well, in the commissioning of your training. I don't know whether you realise, but we get so